Pet overpopulation remains the leading welfare issue surrounding cats and dogs today. Between 4 and 6 million enter United States animal shelters each year, and a large percentage of these animals are the result of unintentional breeding. Despite widespread desire to decrease shelter euthanasia, on average, 70% of cats and 50% of dogs entering shelters are euthanized. There is no question that the single most effective strategy to combat this problem is timely spay and neuter. Pediatric, early age, or prepubertal sterilization refers to the neutering of patients between the ages of 6 and 16 weeks and is supported by the American Veterinary Medical Association. This video provides the veterinary practitioner with the information and techniques required to safely and humanely spay and neuter young puppies and kittens. The methods shown are used by the National Spay-Neuter Response Team of Humane Alliance and are currently being taught at several veterinary colleges, including the University of Tennessee, Mississippi State, and the University of Florida, among others. On-site training is available for both veterinary practitioners and veterinary students at the Humane Alliance National Training Center in Asheville, North Carolina.
For more than 35 years, humane organizations have been sterilizing young kittens and puppies prior to adoption. Understandably, many veterinarians express concerns and questions regarding the short-term and long-term safety of sterilizing pediatric patients. In response to these concerns, numerous controlled prospective studies and retrospective cohort studies have been performed to evaluate the safety of these procedures. Data from these studies suggests that early age sterilization is not associated with serious health problems and is surgically and medically sound. In addition, early age sterilization offers many advantages, including shorter surgical and recovery times, and avoidance of the stresses and costs associated with spaying while in heat, pregnant, or with pyometra.
The safety of administering anesthesia and performing surgery on young puppies and kittens has been very well established. But nonetheless, it's very important for the veterinarian to be aware of the unique physiology and requirements of pediatric patients. In particular, major perioperative concerns include hypoglycemia and hypothermia. In addition, it is very important to minimize fear and stress in these patients. The great news is, with a few simple precautions, all of these concerns can be simply avoided.
Puppies and kittens are in a sensitive period of their development, and fear imprinting can occur when events become severely stressful. In order to prevent undue fear, stress, and anxiety, house littermates together before surgery and as soon as they are able to stand in recovery. And consider the use of pre-medication, especially for patients that are very nervous or uncomfortable. Always handle puppies and kittens gently and soothingly. Most puppies and kittens will respond quickly and positively to human comfort. Young puppies and kittens possess minimal stores of hepatic glycogen, increasing their risk of hypoglycemia. Pediatric patients should not be fasted for more than 2 to 4 hours preoperatively, as they have rapid gastric emptying, and a small meal a couple of hours before surgery will not increase the risk of aspiration. Puppies and kittens can be fed a small amount of Nutrical or a meatball of canned food at the time of physical examination. Once in recovery, their gums may be coated with Karo syrup. If the patient is slow to recover, administer 50% dextrose or Karo syrup. And finally, patients should be fed a small meal once they are standing or within 1 to 2 hours postoperatively. Kittens and puppies have a large surface area to volume ratio and possess immature thermoregulatory systems and lesser fat stores than older patients, predisposing them to hypothermia. To prevent hypothermia, provide bedding and safe, carefully monitored sources of conductive heat and/or convective air warming. Use warm prep solutions and avoid the use of isopropyl alcohol in surgical preparation, since it has a cooling effect upon evaporation. Avoid excessive clipping of the hair coat and large surgical incisions. Minimize surgical and anesthetic time. If fluids are administered, be sure to warm them prior to use. If subcutaneous fluids are given, they should be administered in recovery. Monitor body temperature as needed, and, once mobile, allow litters to recover together.
In order to learn the special knots used in this video for pediatric spay-neuter surgery, we recommend practicing them prior to performing actual surgery on live patients. The following step-by-step demonstrations are meant to allow the viewer to practice and master these techniques. Rubber bands can be used to create models for practicing the knots.
First, a model representing an ovary and uterine horn is created using rubber bands. A towel clamp is used to anchor two of the rubber bands, while the third one is tied to the others. Next, one end of the double loop is clamped to the towel with a hemostatic forceps, and the other end is placed around the handle of the instrument, which is then secured to the towel using a clamp. The tip of the forceps represents the cranial aspect of the animal, while the handle represents the caudal end. The knotted rubber band represents the ovary. The short cranial strand of rubber band represents the suspensory ligament, and the short caudal strand represents the ovarian artery or vascular pedicle, while the long strand represents the uterine horn. The ovary is elevated, and the suspensory ligament and ovarian artery are identified. The suspensory ligament is sharply divided. In order to ligate the pedicle, the hemostat is held in the closed position, with the jaws parallel to the pedicle. It is passed through what would be the aperture in the broad ligament and behind the pedicle. The tip of the hemostat is directed over the near side of the pedicle and is rotated away from the surgeon. The pedicle is clamped with the tips of the hemostats. Next, the pedicle is transected between the ovary and the hemostat, and the ovary and uterine horn are laid down to one side of the surgical field. The surgeon pushes the knot off the tip of the hemostat. The knot is manually tightened, and the pedicle is inspected for hemorrhage. Now, let's take a look at the procedure one more time. The pedicle tie can be performed in other variations based on the surgeon's comfort with instrument and tissue handling. After isolating the vascular pedicle, some may find it easier to direct the ovary to the near side of the table. In this instance, the hemostat will initially be directed away from the surgeon, with the rotation resulting in the jaws of the hemostat directed toward the surgeon. Now, let's take a look at the procedure one more time.
The Miller's knot is a binding knot of the friction knot category, and as such is a very secure tie for ligatures. The Miller's knot is easily learned and rapid to perform as an instrument tie, enabling the surgeon to quickly apply a secure ligature to thick tissues such as the uterine body, eliminating the need for double ligation. The Miller's knot can be used to securely and efficiently ligate the uterine body and may be particularly helpful when tissues are friable. This is because it distributes pressure over a greater surface area than a single encircling ligature, thereby reducing the tendency to cut or crush friable tissue. The Miller's knot is not always necessary in pediatric patients where a simple ligation is adequate, unless tissues are thick or well developed. In older animals, it can be used to ligate the uterus, ovarian pedicle, or spermatic cord.
A tube is used as a model for a uterine body and is secured to the towel using clamps. The Miller's knot is created by passing a length of suture material around the tissue twice, creating a loop. The needle holders are then passed through the loop, and the surgeon proceeds by creating a standard square knot throw. The knot is secured, ensuring that both loops are tightened evenly. Elevating the loops as they are tightened will facilitate this, ensuring that the tissue is thoroughly compressed. The Miller's knot is then finished with a series of square knots to prevent loosening. Now, let's take a look at the procedure one more time. First, 2 rubber bands are used to create a model representing a spermatic cord attached to a testicle. A towel clamp is used to anchor the first rubber band, while the second rubber band is tied to the first. The first rubber band is cut and re-secured using the towel clamp to complete the model. The long strand represents the cord, and the knotted piece is the testicle. The tip of the hemostat is passed under and around the cord. The jaws of the hemostat are then opened as the distal, testicle end of the cord is advanced around and up into them and clamped. Next, the cord is transected between the clamp and testicle, close to the clamp, using a scalpel blade or scissors. Following removal of the testicle, the surgeon pushes the knot off of the tip of the hemostats. The knot is tightened to ensure its security as the surgeon applies gentle proximal pressure. If necessary, excess cord may be trimmed, but it is important to leave approximately 5 millimeters distal to the knot to ensure that it does not unravel. Now, let's take a look at the procedure one more time. The cord tie can be performed in other variations based on the surgeon's comfort with instrument and tissue handling. Some may find it easier to advance the cord down over the hemostats in order to clamp it. The technique then proceeds in the same fashion, as the testicle is removed and the knot is pushed off of the tip of the hemostats and tightened. Now, let's take a look at the procedure one more time.
The figure 8 knot is a modification of the more common cord tie knot. The additional pass through the knot increases friction within the knot. This leads to increased security against untying when the knot is used to ligate the spermatic cord. The technique for tying the figure 8 knot using the hemostat requires only one simple modification to the cord tie. The surgeon holds the testes in the non-dominant hand and wraps the spermatic cord around the hemostat once, then proceeds to perform the cord tie as usual.
Place the hemostat on top of the cord. Wrap the distal testicle end of the cord over the hemostat once. Proceed with the cord tie as usual. Now, let's take a look at the procedure one more time. Here, the figure 8 knot is performed using an alternative variation of the cord tie. Now, let's take a look at the procedure one more time. A veterinarian or veterinary student under their supervision should examine every patient prior to surgery. In the case of feral animals, examination should be delayed until after anesthetic induction in order to minimize patient stress and ensure staff safety. Body weight should be measured and recorded, and body condition assessed. Most surgeons prefer patients to have attained a body weight of at least 2 pounds prior to surgery, though minimum body weight is up to the surgeon's discretion, and some surgeons routinely operate on smaller patients with excellent results. A system should be in place for identification of individual animals, and medical records should be prepared in compliance with state practice acts for every animal. The same general hair clipping patterns that are used to prepare older animals for spay-neuter surgery are used in pediatric patients, with one exception. For male puppies, the entire scrotum and inguinal region are carefully shaved. For female kittens and puppies, the bladder is gently expressed. For scrubbing, an appropriate agent should be used according to published guidelines. A 4% solution of chlorhexidine is an ideal pre-surgical scrub given its broad-spectrum bactericidal effects, its low likelihood of causing allergic reactions, and its extended residual antimicrobial activity. A minimum of 3 minutes of contact time is required to exert its full antimicrobial effects. Warm water or saline should be used for rinsing, taking care not to soak the hair coat. Alcohol should not be used in pediatric patients since it predisposes them to hypothermia by its cooling action.
Veterinarians or veterinary students working under the direct supervision of a veterinarian should perform all surgical procedures. Many of the surgical techniques used to sterilize adult cats and dogs can also be used on pediatric patients. As their tissue is elastic and devoid of excessive fat, the procedure is often easier and takes less time to complete than in adults. The surgeon should make the incision of an appropriate length for the size of the patient so as to minimize surgical time and risk of hypothermia. In pediatric patients, most surgeons prefer to center the incision midway between the umbilicus and pubis. Upon entering the abdominal cavity, a moderate amount of clear peritoneal fluid is often encountered. This is normal. Tissues are fragile and should be handled gently to minimize trauma and reduce the risk of hemorrhage. Pediatric patients have minimal ability to compensate for blood loss, predisposing them to anemia. However, achieving hemostasis is simplified due to the lack of fat and ease of visibility of the pediatric tissues. As always, it is essential to ensure and verify hemostasis.
The ventral abdomen has been clipped and surgically prepared from the xiphoid to the pubis. The umbilicus and pubis are identified, as the incision will be made midway between these landmarks. In pediatric patients, making the incision in the middle third of the caudal abdomen facilitates uterine body ligation. After sterilely draping the surgical site, a 1 to 2 centimeter incision is made through the skin and subcutaneous tissue to expose the linea alba. Scissors are used to remove any overlying fat and subcutaneous tissue. The linea alba or ventral rectus sheath is grasped with thumb forceps, tented outward, and a stab incision is made, taking care to avoid abdominal contents. The incision may be extended according to the surgeon's preference. Here, scissors are used to ensure the peritoneum is sufficiently opened and free of adhesions. Next, the abdominal wall is elevated by grasping the linea or external rectus sheath with thumb forceps, and a spay hook is introduced into the abdominal cavity by sliding it dorsally against the abdominal wall. The hook is then turned medially to ensnare the uterine horn, broad ligament, or round ligament. Pediatric patients, especially puppies, commonly have large amounts of abdominal fluid. This is normal and is not cause for concern. The suspensory ligament is gently strummed to stretch or break it until sufficient exposure of the ovary is achieved. Next, an aperture is created in the broad ligament. Then the ovarian pedicle is double clamped, and the pedicle is transected between the ovary and the distal clamp. The freed ovary and uterus are clamped with a hemostat and laid to one side of the surgical field while the pedicle is ligated. The proximal clamp is removed and a single, secure, simple circumferential ligature is placed around the pedicle at this location, facilitating compression. Prior to releasing the pedicle, it is inspected for hemorrhage. Next, the broad ligament is bluntly dissected to facilitate exteriorization of the uterine body, and the surgeon applies gentle traction to reveal the bifurcation and the contralateral horn. The process is then repeated on the contralateral pedicle. Note that in young puppies, the ovaries generally appear disproportionately large compared to the uterine horns. The size of the ovary and relative lack of fat in pediatric patients makes visualization of the ovary straightforward, facilitating identification and removal. Next, blunt dissection is used to separate the remaining broad ligament from the uterine horns, and the uterine body is fully exteriorized by reflecting it caudally. Clamping is not necessary for ligation of the uterine body, and placement of clamps may cut rather than crush the delicate tissue. To ligate the uterus, a Miller's knot is placed around the uterine body near the cervix using suture of the surgeon's choice, usually a 3/0 absorbable suture such as PDS. Alternatively, a single encircling secure ligature would be sufficient. After the ligature is securely placed, a clamp is placed across the uterine body distal to the ligature, and the body is transected above the clamp. The uterine stump is replaced into the abdomen after verifying hemostasis. The abdominal wall is then closed. The surgeon first closes the linea alba. Large, approximately half-centimeter bites of rectus sheath are obtained. A cruciate suture is placed in the center of the incision. Care is taken to avoid crushing of the tissue by gently opposing the tissue without excessive tightening of the suture. With this suture, square knots with a total of 4 throws are used to ensure security. In this case, a single simple interrupted suture is placed to complete closure of the linea. A long tag of suture is preserved and will be used to facilitate burial of the knot at the conclusion of the suture pattern. The deep subcutaneous tissue is then incorporated into the suture line along with small bites of the rectus sheath in order to obliterate any dead space, minimizing the risk of seroma formation postoperatively. The pattern is continued, incorporating intradermal bites to close the skin. The pattern is completed by securely tying off the suture to the existing tag, using a total of 4 throws, and the knot is buried. Tissue glue is then applied on top of the skin, taking care not to apply it to the subcutaneous tissue. Next, a scoring tattoo is applied adjacent to the incision.
For many new surgeons, one of the most challenging and time-consuming aspects of performing an ovariohysterectomy, whether canine or feline, is locating the uterine horn. When used correctly, a spay hook can increase surgical efficiency, minimize tissue handling, and trauma. Becoming proficient with a spay hook takes practice. Remember to introduce the hook into the abdomen by elevating the body wall and holding the hook against it while advancing it far dorsally. The hook should then be turned medially and gently extracted from the abdomen to ensnare the uterine horn where it lies under the bladder. With experience, the surgeon can often identify whether or not the uterus has been ensnared by feel. When hooked and gently elevated from the abdomen, a small amount of tension is created, which combined with the elasticity of the tract produces what can be described as a springy feel. If the uterine horn cannot be located with the spay hook, retroflexing the bladder through the incision will allow the surgeon to readily locate the uterine body between the colon and bladder. Let's take a minute to talk about the puppy or kitten smooth down and shakedown techniques. Prior to surgery, it is always important to verify that both testicles are present in the scrotum so that the surgeon can plan accordingly if cryptorchidism exists. In the case of pediatric patients, the small testicles can easily retract into the inguinal area, especially once the patient is anesthetized and placed in dorsal recumbency. Furthermore, if the inguinal rings are still open, it may even be possible for the testicle to slip back through the external inguinal ring into the canal or abdomen. If this occurs and the testicles are absent from the scrotum, we commonly will do a little shakedown technique, which consists of supporting the puppy's chest and gently giving just a little shake to help encourage those testicles to slip back into the scrotum. Also, we will commonly put digital pressure over the inguinal rings and smooth toward the scrotum to encourage the testicles to reappear in the sac. Next, we're going to demonstrate the scrotal approach in puppies. The approach requires incision over the scrotum and self-ligature of the spermatic cord. Both the figure 8 and cord tie are acceptable means of ligation via scrotal approach in the puppy. For larger dogs, a Miller's knot or circumferential ligature may be considered.
Note the entire scrotum has been clipped and prepped for surgery. The surgeon grasps one testicle, positioning it such that the median raphe is elevated and exposed. The incision is made through the skin and subcutaneous tissue along the median raphe over the displaced testicle. The incision is continued through the spermatic fascia to exteriorize the testicle. An open or closed technique may be used for castration according to surgeon's preference. Here, the testicle is fully exteriorized using gentle traction as the surgeon reflects fat and fascia from the parietal tunic of the spermatic cord using a gauze sponge. A figure 8 knot is used to ligate the spermatic cord, and the cord is transected, taking care to leave a 4 to 5 millimeter tag to ensure the knot cannot unravel. Prior to releasing the cord, the knot is tightened. As the cord is released, hemostasis is verified. The procedure is repeated for the second testicle, which is removed through the same incision centrally located in the scrotum. Closure is accomplished by applying a drop of tissue adhesive on top of the skin, which is inverted slightly, taking care not to apply adhesive to the subcutaneous tissue. Alternatively, the incision may be left open to heal by second intention. Lastly, a scoring tattoo is applied near the prescrotal area.
For the kitten spay, a technique known as the pedicle tie is used for ligation of the ovarian pedicles. This technique is analogous to self-ligature of the spermatic cord or cord tie as performed in the cat castration. This technique allows the surgeon to efficiently and securely ligate the pedicles without the use of suture material. Although less well known than the cord tie, the pedicle tie has been used by many veterinarians for decades and was recently described in the veterinary literature.
The ventral abdomen has been clipped and surgically prepared from the xiphoid to the pubis. The umbilicus and pubis are identified, as the incision will be made midway between these landmarks. In pediatric patients, making the incision in the middle third of the caudal abdomen facilitates uterine body ligation. After draping the surgical site, a 1 to 2 centimeter incision is made through the skin and subcutaneous tissue to expose the linea alba. Scissors are used to remove any overlying fat and subcutaneous tissue. The linea alba or ventral rectus sheath is grasped with thumb forceps, tented outward, and a stab incision is made, taking care to avoid abdominal contents. The incision may be extended according to the surgeon's preference. Here, scissors are used to ensure the peritoneum is sufficiently opened and free of adhesions. Next, a spay hook is introduced into the abdominal cavity by sliding it dorsally against the abdominal wall. The hook is then turned medially to ensnare the uterine horn, broad ligament, or round ligament. Any omentum or fat is freed from the hook, and anatomic conformation is then used for the identification of the uterine horn by following it to the ovary. With gentle traction on the uterine horn, the ovary is exteriorized from the abdomen, and the surgeon is able to identify the suspensory ligament by palpation as the taut fibrous band at the proximal edge of the ovarian pedicle. The suspensory ligament is then transected to aid in isolation of the vessel. Excess tissue should not be left with the vessel, as it will be integrated into the ligature and could compromise knot security. Next, using either sharp or blunt dissection, an aperture is created in the broad ligament adjacent to the ovary. Again, this is performed as close to the ovarian artery as possible so as to completely isolate the vascular pedicle in preparation for ligation. The surgeon then holds the ovary in the non-dominant hand and gently directs it to the far side of the surgical field, while a hemostat held in the dominant hand is passed behind the vessel and through the aperture in the broad ligament. The hemostat should be held in the closed position, with the jaws pointing toward the surgeon. The tip of the hemostat is then directed over the near side of the vessel, and the entire instrument is rotated so the jaws are now facing away from the surgeon. The jaws are then opened and the vessel is clamped. The vascular pedicle is transected between the ovary and the hemostat, and the uterine horn and vessels are clamped with the hemostat and laid down to one side of the surgical field. Now, let's take a look at the procedure one more time. The surgeon then pushes the knot off the tip of the hemostat. Care should be taken not to place excessive traction on the pedicle. Prior to releasing the hemostat, the knot should be tightened and the pedicle inspected for hemorrhage. The process is repeated on the contralateral pedicle. Note how the surgeon uses her finger behind the pedicle to spread the tissue in order to facilitate visualization and separation of the suspensory ligament and vessel. The pedicle tie can be performed in other variations based on the surgeon's comfort with instrument and tissue handling. For example, some may find it easier to direct the ovary to the near side of the table after isolating the vascular pedicle. In this instance, the hemostat will initially be directed away from the surgeon, with the rotation resulting in the jaws directed toward the surgeon. Next, the broad ligament is separated from the uterine horns, and the uterine body is fully exteriorized by reflecting it caudally to expose the bifurcation. Clamping is not necessary for ligation of the uterine body, and placement of clamps may cut rather than crush the delicate tissue. To ligate the uterus, a Miller's knot is placed around the uterine body near the cervix, using suture of the surgeon's choice, usually a 3/0 absorbable suture such as PDS. Alternatively, a single encircling secure ligature would be sufficient. After the ligature is securely placed, a clamp is placed across the uterine body, distal to the ligature, and the body is transected above the clamp. The uterine stump is replaced into the abdomen after verifying hemostasis. The abdominal wall is then closed. The surgeon first closes the linea alba. Large, approximately half-centimeter bites of rectus sheath are obtained. A cruciate suture is placed in the center of the incision. Care is taken to avoid crushing of the tissue by gently opposing the tissue without excessive tightening of the suture. With this suture, square or surgeon's knots with a total of 4 or 5 throws are used to ensure security. If needed, a single simple interrupted suture is placed on either side of the cruciate to complete closure of the linea. The deep subcutaneous tissue is then incorporated into the suture line along with small bites of the rectus sheath in order to obliterate any dead space, minimizing the risk of seroma formation postoperatively. A long tag of suture is preserved and will be used to facilitate burial of the knot at the conclusion of the suture pattern. The pattern is continued, incorporating intradermal bites to close the skin. The pattern is completed by securely tying off the suture to the existing tag, and the knot is buried. Tissue glue is then applied on top of the skin, taking care not to apply it to the subcutaneous tissue. Next, a scoring tattoo is applied adjacent to the incision.
A common question we are often asked is if the pedicle tie can be used in older or larger cats or in other species. In fact, there are no general limitations on the use of the pedicle tie in cats. However, the surgeon should develop skill in its application prior to performing the technique on cats with larger ovarian vessels, such as those that are inheat or pregnant. The fact that the feline suspensory ligament contains few blood vessels and a negligible amount of fat makes this procedure safe in cats. In contrast, the pedicle tie is not appropriate for use in other species such as dogs and rabbits. In these species, the large amount of fat in the suspensory ligament makes isolation of the vessels and secure knotting problematic.
The cat is positioned in dorsal recumbency with the hind legs pulled cranially. The entire scrotum has been clipped and prepped for surgery. After draping the surgical field, the surgeon grasps one testicle and incises the overlying skin and subcutaneous tissue. The incision is continued through the spermatic fascia to exteriorize the testicle, and then gentle traction is applied to achieve maximal exteriorization. A figure 8 knot is used to ligate the spermatic cord. And the cord is transected. taking care to leave a 4 to 5 millimeter tag to ensure the knot cannot unravel. Prior to releasing the cord, the knot is tightened. As the cord is released, hemostasis is verified. The procedure is repeated for the second testicle. Note that in order to maintain closed technique, care is taken not to incise the parietal vaginal tunic and tunica albuginea. As needed, the surgeon uses a gauze sponge to reflect fat and fascia from the parietal tunic prior to ligation. After removal of both testicles, the surgeon gently elevates the skin surrounding the incisions to ensure the ligated cords retract inside. Any tags of tissue protruding from the scrotum should be resected. The incisions are left open to heal by second intention. A scoring tattoo is applied to the ventral midline.
Either the figure 8 knot or the cord tie is an acceptable means of ligation. An open technique is also acceptable for kitten castration and occurs if the surgeon continues the incision through the parietal vaginal tunic.
Published veterinary medical guidelines call for spay-neuter programs to choose a consistent means of identifying animals that have been neutered. To accomplish this, a simple tattoo technique that does not require special equipment is recommended. Animal tattoo ink in the form of paste is used to create a simple line on the ventral abdomen or inguinal region to mark the animal. Green paste is preferred since it is easily recognizable and unlikely to be mistaken for natural pigmentation, as with black ink. Examination for a ventral midline scar or spay scar is a standard practice to determine sterilization status of females. Thus, the presence of a green line in this area would be easily discovered and could verify that surgical sterilization had been performed. After surgery, the tattoo should be shown to the owner and described in the written discharge instructions to prevent unnecessary concern if the owner notices the green ink. To create the tattoo, the surgeon uses a scalpel blade to gently score the skin adjacent to the surgical incision and applies a tiny amount of paste into this incision. This is called a scoring tattoo, since the skin is scored fully through the epidermis into the dermal layer with a scalpel blade, and paste is then applied. A paper sterility indicator strip from the surgery pack may be conveniently used to paint the inside of the incision with paste. Afterwards, the skin edges are slightly inverted, and a drop of tissue adhesive is applied on top of the skin for closure. The application of the tissue adhesive prevents patients from licking the tattoo and developing a temporary case of green tongue in recovery. Both male and female cats and dogs should be identified with a scoring tattoo at the time of spay-neuter surgery. For females, the tattoo is applied near the ventral midline incision. For male puppies, it is applied near the prescrotal area, where a scar might be expected from castration surgery. In tomcats, a patch of hair should be clipped from the ventral midline and the tattoo applied as in females. This will serve to prevent an unnecessary laparotomy should the neutered tom ever be mistaken for a queen.
We hope that viewing this video has provided you with the necessary guidance and information to master the skills required to safely and humanely perform pediatric spay-neuter. Although it may seem intimidating at first to operate on a pediatric patient, we assure you it is much easier to spay a 2-pound kitten than it is to spay an 8-pound queen, or to spay a 5-pound puppy than to spay an 80-pound adult. We encourage you to practice these skills using the dry lab techniques, and then to apply your new knowledge and skills to perform surgery on young puppies and kittens awaiting adoption at animal shelters. For practitioners in small animal practice, we strongly encourage you to schedule your patients for surgery immediately following vaccination at 4 to 5 months of age. we are confident you will see shorter surgical and recovery times for your patients.
In conclusion, the American Veterinary Medical Association recognizes the need for veterinarians to take a leadership role in effective efforts for dog and cat population control and encourages veterinarians to perform early age sterilization. By performing timely spay-neuter procedures, veterinarians can enhance the welfare of their patients and reduce the number of homeless pets entering shelters. For more information, please contact the Humane Alliance or visit www.humanealliance.org.